All right, let's get this patient some oxygen while we're waiting. Can we get a history on this patient?
Yes. Today we have here Susie Collins, female 36. She, approximately 2 hours ago, Susie became increasingly short of breath while at work, and this did not improve with her usual use of inhalers. On realizing this, colleagues called an ambulance promptly, and Susie was assessed at the scene and given high-flow oxygen before being brought into the emergency room for further assessment.
Also put a telemedicine strip on her.
Okay. What do you see on the screen?
Her heart rate is 125, BP is 130/90, and her oxygen saturation is 95.
Alright, I'll quickly listen to her heart and lungs. So normal S1, S2, no rubs, clicks, murmurs, or gallops. Looks like there isn't any accompanying cardiology pathology that could be contributing to her symptoms.
Seems like she's having an acute exacerbation of her asthma, and we should start on some albuterol. This will relax her lung muscles and allow more air into her lungs.
Yeah, some wheezing is heard in her lungs. It doesn't look like there's any obstruction that could be the source of her issues.
I'm going to be administering 5 milligrams of albuterol via nebulizer.
Okay.
Put her on a high flow rate.
Yep. Put her at 15. Okay. And it should be available for us.
Taking off the oxygen, putting on the albuterol on a non-rebreather.
Blood pressure 130/90, O2 sats 95. Heart rate is not given.
Get the telemetry straight up on it.
There we go.
Heart rate 132.
All right, Susie, we gave you some albuterol inhaler in this mask that we gave you, okay? It's the same medicine you take at home to help open up your airways, okay, so you can breathe.
With her condition not improving, we could move ahead with the corticosteroid. She seems to be getting worse.
All right, so what we've seen is kind of a deterioration in her respiratory status. She's tripoding, using accessory muscles to breathe. We need to escalate the protocol regimen and get a ipratropium or some kind of steroid on board as well.
Yeah, heart rate is 140, blood pressure 130/90, O2 sats 94, stable.
All right, Susie, we're going to get that medication for you as soon as possible, okay?
I've ordered ipratropium in nebulizer form, and we're going to also put that up at a high flow rate.
I'll take her off the albuterol.
The equipment is ready.
Let's get that ipratropium, okay?
O2 sat is at 92 right now, heart rate 140. Now its heart rate is at 110. O2 sat's 99, stabilized.
Good.
Blood pressure is still slightly elevated, 130/90.
I'm glad you're feeling better, Susie. We got you a different medication that's kind of opened up your airway a little bit, okay? It seems like you're doing a lot better.
Have our inside lung software demonstrating a little more about the anatomy of what's happening during an asthma exacerbation. So here, if we click on the lung,
the healthy lung.
So here you can see
rest,
the inspiration and expiration of the lung.
Breaths per minute.
On the right, you see an
Inhale
alveoli
and exhale,
here,
7
and you can
to
see
8
the nice,
liters of air.
well-dilated
The total
airway.
surface area of healthy adult lungs is approximately 70 square meters, the size of half a tennis court. Mild asthma.
As you can see with
Individuals are
asthma,
mostly free of symptoms. For
here
example,
in the
coughing and
alveoli, you see this little bit of
Some inflammation
bronchoconstriction
and
that's
constriction of the
happening and a
smaller
little bit of
airways is seen in
inflammation
the
that's
some mucus
happening.
production.
And as a
Waking up
result,
in the
as the
night with
airway
some symptoms
narrows,
is not
one
usually
thing
a
that's
problem.
happening is that it's
Individuals
harder
have
to
a
move
reasonable
air
level
back
of
and
daily
forth,
activity.
and also
Lung
because
function
of the
measurements,
higher
known as spirometry, are usually normal
restriction
or only
of air
slightly
moving
reduced.
across
With
the
FEV1
narrowed
of
airway,
at
you get a
least
wheezing
80%
sound
of the
as
predicted
it's
normal value.
inspiration and even in
Rescue
expiration.
medication is often used more than twice a week, but not daily. Controller maintenance medication is used as per guidelines in your asthma exacerbation.
So when you have a severe
Symptoms include
exacerbation,
severe
now
wheezing,
here you see the
chest
airways
tightness,
almost completely
coughing,
closed in the
difficulty speaking,
alveoli,
and very rapid
and the
breathing.
lungs are very
During an
inflamed.
asthma attack,
This is
also
from the
known as an
acute
exacerbation,
response
the airways
from the
become very
exacerbation,
narrow or closed
and that
due to muscle
inflammatory
spasms around the
response
airways.
in
More
response
and thicker
to
mucus is produced,
the
and there is swelling
exacerbation
of
as
the
well as
airway
the
lining,
bronchoconstriction
mucosa.
really limits
Normal
air
activity
exchange.
is not possible.
So
The
in,
individual is in crisis.
so in this
The
crisis
individual will
mode,
struggle and need to work hard to breathe.
the
This can be
individual is
potentially
struggling
life-threatening.
and trying to
Treatment
breathe.
as per
That's why you see the
guidelines in your
retraction
country.
during breathing. And to really get over the exacerbation, you need two things. One is you have to bronchodilate the patient so that airway starts to open up here. But then the other thing is you see all that inflammation at the level of the alveoli. So the best way to rapidly treat inflammation is with a high-dose steroid, which is given intravenously. So in our scenario, giving both bronchodilator, additional oxygen, and the intravenous steroids really helps to break the asthma exacerbation. And once that's done, you kind of get back to where you see more of a healthy lung pattern. Let's see if that'll work here.
The healthy lung.
So here
At
again,
rest,
you can
a
see there's
healthy
no
adult takes
inflammation,
around 12
and the
breaths per minute.
alveoli here is
Inhaling
nicely
and exhaling 7
pink
to 8
and
liters of air. The
functioning
total
well,
surface
and the
area of healthy
bronchiole
adult
is
lungs
nice and
is
dilated.
approximately 70 square meters, the size of half.
So that's a little bit about the anatomy, and now let's go back to the scenario.
All right, so let's try debriefing a little bit. So you guys had an initial. How did she present? What was happening with her when she came in initially?
Patient came in, she was tripoding, having difficulty breathing, using accessory muscles to breathe. She had already used albuterol, so like we needed a higher level or higher strength bronchodilator.
So You tried something initially. What did you all try initially? The initial medication that you tried putting.
So we tried albuterol, which is a beta 2 agonist, and what it does is it and agonizes the beta 2 receptors to open up the airway a little bit more. However, it seems like she's already taken an inhaler, and that's what led to this asthma exacerbation. She's already taken an inhaler and she had an asthma exacerbation on top of that, so we needed something a little bit stronger.
And as you said, so what did you do at that point? What do we give her at that point?
We gave her ipratropium bromide, which is a M3 muscarinic antagonist, which is another bronchodilator. It works within the acetylcholine pathway.
All right. So what are we thinking about in terms of long-term care for our patient here and concerns for the future?
So long-term care, I think having the albuterol rescue inhaler on board is a good option, but we can also add other agents on board to her regular maintenance therapy. We can add ipratropium as well as a inhaled steroid that she can take every day. Add the antimuscarinic. There's also other options that we can add on board as well. So things like steroids. So we can do some sort of inhaled corticosteroid that can help release all of that inflammation and allow her to have fewer asthma exacerbations in the future.
Any other concerns or thinking in terms of following up and working with her for the future?
We'd want to make sure that she's using her albuterol inhaler correctly. Sometimes without use of a spacer, the medicine can be administered to their mouth rather than fully down their throat and more so into their lungs. So after this, we continue to monitor her, get her stabilized, talk about history, and then future lifestyle, as well as medication procedures.
All right. Any other thoughts?
Probably also get a history of atopy and eczema because those can be associated with asthma as well.